Good evening or good afternoon. I'm Victor Zhao, the President of the National Academy of Medicine, and welcome to the 7th webinar in the COVID-19 Conversation series. It's brought to you by the NAM and the American Public Health Association. The purpose of this series is to explore the state of the science on COVID-19, to inform policymakers, public health and healthcare professionals, scientists, business leaders, and the public. I'd like to thank my co-sponsor, APHA Executive Director, Georges Benjamin, as well as the co-chairs of our webinar series advisory group, Carlos Del Rio of Emory University, and Nikki Lurie, former Assistant Secretary for Preparedness and Response. More information on the series and recordings of past webinars are available on covid19conversations.org. Today's webinar has been approved for 1.5 CME credits for CHES, CME, and CPH. None of the speakers have any relevant financial relations to disclose. Please note that if you want to continue continue education credit, you should have registered with your first last name. Everyone who wants credit must have their own registration and watch today's event in its entirety. All of the participants today will receive an email within a few days from cpd@convex.com with information on claiming credits. And all online evaluation must be submitted by June the 26th, 2020 to receive continued education credit. If you have any questions or topics you'd like us to address today or future webinars, please enter them in the Q&A box or email us at apha@apha.org. If you experience technical difficulties during the webinar, please enter your question in the box. Please pay attention to the chat for announcement about how to troubleshoot. This webinar will be recorded, and the recording, transcript, and slides will be available on covid19conversations.org. Now I'd like to begin the session today and introduce our moderator, Dr. Scott Gottlieb. Scott is a member of National Academy of Medicine and a former commissioner of the FDA. He's currently a resident fellow at the American Enterprise Institute, where he focuses on improving public health through entrepreneurship and medical innovation, and expanding regulatory approaches to maintain patient and physician autonomy. Scott is a major leader. I've been very impressed with him, and he will lead the conversation today. So Scott, over to you.
Thanks a lot. Thanks for having me here today. I want to thank all the distinguished panelists who are joining us. It's really an honor to be leading this discussion. I thought I would just start out with a few thoughts of my own and then introduce the panel and then turn it over to them. And around 6 o'clock, we'll start with questions from the audience. So please send your questions in and I'll turn it over to the audience and read the questions that we get. We've really been in a period of time right now where we're facing a once-in-a-generation pathogen, and we should recognize, what we've done to help prevent the worst outcomes and the worst epidemic based on the early estimates that we had, and avoid the worst consequences. But we also need to recognize that we paid a heavy price for this, both an economic price and a public health price, in terms of the implications of the mitigation and the implications of the shutdown. There were bad consequences on both sides of this ledger. There were no easy choices here. There were no good outcomes. We chose the path of preserving life, but we all did it, I believe, with eyes wide open on how hard this road would be and how many consequences there would be, and how many challenges really lie ahead. We are not out of the woods. This is going to be a very long road. People rightly want to know when this is going to be over, and the answer is it might not be over for a very long time until we're able to more fully vanquish this pathogen with our technology. And this may be an infection that's with us in perpetuity, that becomes endemic, but becomes something that we can live with and that we can conquer with vaccines and with therapeutics. But in the interim, until we get there, until we get that technology, we're going to need to define a new normal. Until we have those better drugs and a vaccine, we need to define a new normal where we can get back to the things we enjoyed. We can get back to work, but we're going to have to do so differently. We're going to have to do so in ways that we apply more vigilance to what we do. We're going to have to sacrifice certain trappings and impose certain things that will make life different. And we're going to have to do things more safely than we've done before, and with more awareness to the risk of viral transmission. Now, there's a lot of signs of progress when you look at the data. The US had been in sort of this extended plateau, both when you included New York and even when you backed out New York, you were seeing an extended plateau in terms of the number of new cases on a daily basis and the number of deaths. But if you look at the data over the last couple of weeks, and we have some experts on the panel who look at the data much more sharply than me and will be weighing in on this, you see signs of progress. You see reductions in hospitalizations and new cases, even as testing increases. You see declines in positivity rates. You've seen a trend towards a sustained reduction in new cases, even when you exclude New York, but certainly when you include New York in the overall data, because New York is obviously experiencing sharper declines over a longer period of time than other parts of the nation. Now, that's not to say it's all easy roads ahead. When there are states that have large outbreaks, there's states where the number of new cases are going up. There's at least 10 states that where the R is above 1.1 and maybe at 1.2. The doubling time is still probably around a month or more, and we still have a slowly expanding epidemic, but there are signs of progress, and there are signs that the mitigation is working, not just in the hard-hit cities like New Orleans and New York and Detroit and Michigan and Boston, but around the nation, even as we reopen against a backdrop of spread. And we reopen in a setting where some states are experiencing increases in new cases. Now, there's a way to do this with reduced risk. We have to focus on at-risk communities, people who lack access to testing and good care because of places where they work or they live. They might be at higher risk for the infection. We need to try to put forward thoughtful guidances for businesses on how to reopen safely and for recreational activities. We need to invest in public health tools like track and trace and trying to do the blocking and tackling of public health work, of tracking down people who have the infection and people who they might have been in contact with, and offering them testing and asking people to self-isolate for the period of time that they're infectious. This is a highly infectious pathogen. We're not going to get everyone. We're not going to be able to track down all the cases, but even if we can track down a meaningful fraction of the cases, that might be enough to keep this epidemic from expanding, and we have to try. These are the tools we have to lean on now. As we move away from the population-based mitigation, we can move towards the case-based interventions and lean very heavily on them. A lot of this, and certainly part of it, but probably a lot of it's going to turn on better data on how to target these interventions more effectively, data on who's being disproportionately impacted by the infection, data on how to get testing into the community settings where it's going to have the biggest impact, because not everyone's at equal risk, and we need to identify the groups that are at the most risk and make sure that we're marshaling services and resources into those settings. And so here to talk about that today is a really great panel, and I'd like to introduce them and then turn over some questions to the group. Mary Bassett is director of the FXB Center for Health and Human Rights and a professor at Harvard University and a former health commissioner for New York City. Heidi Larson is a professor of anthropology, risk and decision science at the London School of Hygiene and Tropical Medicine and a member of the webinar series advisory group. David Michaels is a professor at George Washington University and a former assistant secretary of labor for occupational safety and health. And Chris Murray is director of the Institute for Health Metrics and Evaluation at the University of Washington, which maintains the model that we're all very familiar with, COVID-19 model that's become very influential, very closely watched by all of us, and has been a subject of many of my tweets. So thank you, Chris, for giving me material. I want to thank you all for being here. We now have about 50 minutes for open discussion among the group, and then I'm going to turn it over to questions from the extended audience. So I just want to start out with one question, and I'll direct it to you, Chris, first, and then maybe everyone else can comment. What data do we currently have that can help guide specific measures on reopening decisions? What do you think we have in terms of effective data sets, and what do you think we need to make these decisions more intelligently, more effectively?
Thanks, Scott. Thanks for the intro and the question. You know, I think what's been impressive during the pandemic so far is the extraordinary value of daily data. And that's what we're all living and breathe right now, coming in from states and counties. On the other hand, what's been impressive is how hard it has been to go beyond case reporting and death reporting. So you mentioned hospitalizations. It's a great indicator that is less subject to the bias that's in cases, because as we scale up testing, we will inevitably find more cases. And so the trend in cases becomes really hard to interpret, but not that many states are reporting admissions. Some states report census counts in hospitals, other states don't report at all. When it comes to testing, which as you said is going to be so important for the next wave of the strategy, we really must know the difference between testing of people who show up at a hospital or a clinic with symptoms and testing out in the community, where we're proactively looking for groups at risk, vulnerable groups, or contact tracing, and yet that basic information is not currently available. And as you go ahead a little bit to, you know, what's the early warning system for the next flare-up or the next hotspot, I think we may need to start thinking about other innovative strategies that go beyond the testing data, go beyond, you know, hospitalizations and case reports. There's lots of interesting ideas out there. They're not ready for prime time. Things like water treatment testing, or, you know, sewage treatment testing that might give us through quantitative PCR a sort of signal of how much virus is in a particular community. Lots of possibilities. I think we're going to want to understand those data sources as they may or may not come online.
Mary, can I ask you to comment? I'll just go down the panel if that's okay.
Sure. Well, one of the things that has emerged very rapidly in terms of the data are large race ethnic disparities in both cases, the number of people who are tested positive and in deaths. But the race data are really woefully incomplete, including for death data. In Massachusetts, where I am now, over half of deaths have no race recorded. So it means that it's difficult to, just as it is with testing, period, we still haven't gotten testing up to the levels that it should be to be confident that it reflects the prevalence in the population. We also don't have good data, but the data we have suggests that the excess risk among Blacks and Latinos, Native Americans ranges 2 to 4-fold. I'm not sure why the data aren't better, but they should be.
Yeah, I was going to ask you why it's been so challenging to get good data, because it does feel like a frustration. Data about who's being affected, data about outcomes. We haven't seen a lot of systematic data. We now have 1.4 million Americans who've been infected, hundreds of thousands who've been hospitalized. We haven't seen a lot of systematic reporting on the collected clinical experience. Do you have any insight into why it's been difficult?
You know, the electronic health record was supposed to fix this for us, but I think everybody on the panel will agree that it's just been extremely disappointing.
Yeah, a lot of the clinical information that we're using to make judgments right now is coming from Europe and China, and not from our own collected.
Right. I'm afraid I can't help. Maybe somebody else can come in here, but I really can't tell you. But it's not good enough, and it can be fixed.
Yeah. Heidi, any thoughts on?
Well, I think, as Chris says, you know, most of the data out there is case and death, to the extent that even that is straightforward. But there's other kinds of data that we could be tapping into. I mean, in our research, we do a lot of social media monitoring. We do look at Google searches. We look at, you know, and there are ways to start looking into other data sources for symptoms, for people searching on for what's going on, or talking about new cases or behaviors. We're also doing starting to launch some pulse surveys that ask, not just people's experience around this, but are they going for testing? Do they want to get tests and can't? Or, I mean, I think if we open the box of different types of data, it might give us some other access. When you go into those types of data, you don't have as much information necessarily. They're not all geotagged. They're not, you don't know who's telling, who's really behind some of the social media data. So but I think as an additional supplementary indicative source of information, I think we should try to think about ways to use it in a much more systematic way.
What do you think, what information do you think is going to be most important for people to make decisions at a local level or a state level as they start to reopen businesses? What kind of data do you think we should be relying on that in and of itself is also reliable, that we can get access to?
Well, I mean, I think people share a lot of information online and in social media communication, and you can, I mean, I'm sure you can at least get some indicative signals that people are talking about cases, or they're talking about where they can get treatments, or can they get treatments, or you can pick up on a feeling that something's going on there. And as you say, it's highly infectious. Again, this isn't kind of definitive data in the same sense that you get kind of health data from official sources, but it does give you, especially for kind of warning signs or signals that we should work into the risk assessments. You can also ask. I mean, I think surveys could be used more in different contexts.
I really think we just got to do better on testing. And we
Yeah.
have to get the actual, and at least in the United States, if that's what we're talking about. I can't really see a good reason that we can't get the testing rates up to much higher levels than they are now. We should be able to do that. We should be able to get better prevalence estimates. And that's really a key driver. It's important to see the presence because, as Scott, you said in your introduction, there is variability. We could classify the country into sort of green zones, yellow zones, red zones, but we need data in order to do that. And we can get hints, as Professor Larson is outlining, but I think we should just say there really ought to be adequate testing.
Where do you think we should be in terms of testing? Where do you think we can be?
I mean, the numbers that are being estimated run from 150,000 to 5 million a day. I read recently that the U.S. hit 400,000, and that was the first for national numbers of tests per 100 for the country. So I think that maybe this is a question for Chris. That there's a very big range, but it certainly needs to be much higher than it is.
Yeah, I mean, I'll just inject. I want to turn to David, but for his initial thoughts, okay. I'll just inject a thought here, and I'm going to come back to Chris with another question. But I think that the challenge is that we've been trying to use a PCR-based platform in this country to do most of the testing, and PCR has certain advantages, but certain disadvantages in terms of timeliness of turning around a test. And if you look at the capacity of the PCR-based system, we probably will max out the capacity of the existing platforms in the supply chain at about 500,000 tests a day. And we're getting close to probably about 300,000 tests a day. So I think our ability to get more testing is going to be dependent upon getting different kinds of testing platforms and different kinds of technologies and putting the right platform in the right setting where it's properly fit for purpose. So in a primary care setting where you have a doctor providing the intervention, the Abbott system or an antigen-based system that might have very good specificity but doesn't have perfect sensitivity might be perfectly appropriate, because that doctor in that setting, if they get a negative test but they suspect the patient has coronavirus, they're going to send off a confirmatory PCR test. And so you want to deploy those point of care systems. PCR can be a very good platform for confirmatory testing, and then also for doing some primary testing, particularly around settings where you need a definitive result, you need a high sensitivity. But then to do mass screening, if you want to do workplace testing where you might want to do pooled samples, you need something that has a much higher detection rate. So things like next generation sequencing, which I've worked with in my private life, where you're looking for, 200 amplicons as opposed to 2. So you have a much better ability to detect virus in a pooled sample. That might be an appropriate technology for that purpose. And so I think we need the only way we're going to get broader testing, in my view, is to get more technologies, but then make sure the technologies are appropriately used. So for example, you shouldn't be using the Abbott machine to do asymptomatic screening of people outside of a clinical setting, because you're going to have a false negative rate. And outside of a clinical setting, you won't follow up those individuals. So, that's just my injection as a moderator. David, can I just turn to you for your thoughts? I'm sorry.
No, I think we see a lot of the same problems when we think about from the worker safety point of view. But COVID-19 has become a massive worker safety crisis, and the communities with the highest infection rates, the ones where the infection rates are rising rapidly, are those places where the epidemic is being driven by job-based exposures. And so you've got extensive testing in some workplaces, most famously, the protein industries, pork, beef, and poultry, and warehouses, farms, some other workplaces. But there's very little testing done in many workplaces. And for the most part, and this is sort of the equal part of the problem, there's no linkage between public health authorities and a lot of the testing that's done. There's a famous example now up in a Walmart in Worcester, Massachusetts, where there have been so far 85 cases and 2 deaths. When the initial cases started to appear, local health authorities had no idea they were all linked to one workplace. Once they finally put it together, they shut down the store. But they've said if they had known earlier, if the reports had come into them directly, they could have gone in there much earlier. And we don't yet have that tracking and tracing. So we actually need, in addition to good testing, sort of a workplace-based surveillance system where workplaces are identified where transmissions are occurring. When employers do that testing and they learn about it, they need to notify local health authorities. They need to be working closely with OSHA and other agencies to figure out what needs to happen immediately in that workplace, because that's where a lot of these transmissions are occurring, I think.
Do you see best practices that you would point to and where that's happening effectively?
Well, I certainly hear that. I haven't, I've gotten reports from Washington State and Oregon where there seems to be a real collaboration between state health departments, a lot of the employers where they're doing that, but I haven't seen much of it. The other thing we're seeing, unfortunately, is this real tension, certainly in some of these big industries where, we heard, for example, that the meat industry in Nebraska didn't want to actually release any numbers about what was going on in their workplaces. They told the health department they didn't want any sort of intervention. So we've seen sort of worst practices, but I haven't seen too many of these best practices yet.
How much, I want to just shift a little bit to, where we are right now in terms of starting to contemplate a staged reopening of the economy, really across the nation.
No, not that one.
Really,
Orange.
really.
Somebody needs to mute.
I want to pivot to a discussion of what we're contemplating now, which is really a staged reopening of the economy across the nation, with different states taking different measures, different staged approaches to reopening, and just ask the group, how much do we feel that the data we have is adequate for making those decisions? What should we be relying on as we make those decisions? And any observations as you see some states step forward, or states that are doing it well, states that are looking at the right data, making the right decisions relative to the data. And if anyone wants to dare to comment on states that they feel maybe aren't looking at the data that they have in hand and making decisions that are appropriate relative to the data set and what the data should be telling them. And I'll just toss it out there without picking on people and see if anyone wants to jump at that. And then I want to pivot and ask, after that, I want to ask Chris some questions and into the whole group about just handling how we grapple with when these questions of data get pulled into sort of a political context where people are looking at the data through a lens of their particular sort of mindset about the about the epidemic and how we deal with that. But I'll turn it over to the prior question about the states and the data and how they're using it.
You know, Scott, I think the issue there is we can give, or at least I can give, a public health or a health outcome answer, but most of the states are trying to balance the economic turmoil from shutdown versus the health outcomes. Clearly, from a pure health point of view, not the balancing act that they have to go through, many states are opening up before they have clearly brought transmission down to a reasonably low level where the testing and contact tracing and isolation strategies are likely to succeed. So I think that's, you know, and Georgia is a great example of that sort of situation where there's relaxation. They haven't even peaked necessarily. Lots of other examples we can look out there. So it's really easier for us to give the public health answer, much harder to think about that balancing act between public health and economic impacts.
Anybody else want to touch that, or because it does seem like there's heterogeneity across the nation in terms of the kinds of metrics that states are looking at, and the point at which they're making decisions to start to reopen relative to the data. And there's heterogeneity also in the risk that different states face. Some states have less density. Some states have had less overall infection. At the outset, they're in a position to take more risk. So it's very hard to make comparisons across states. The states are in very unique circumstances. But, you know, to the extent that there is some commonality, it does seem like there's a lot of heterogeneity in how decisions are being made across the country. So, but
I think that everybody agrees that the cases shouldn't be going up. If from the public health point of view, if you're still seeing the case counts going up every day, then you haven't succeeded yet in reducing transmission. So that is worrying, because that's been our principal strategy, that to reduce the contact between people has been what has led to the flattening of the curve. It's not just imaginary that as you increase the amount of mixing of people in the population, transmission will go up. We've seen it happen across the Asian cities that successfully brought down transmission. Wuhan said that they had 0 cases and now has had a reintroduction. So we've seen, clusters return even when there was fairly good control. So it's very worrying to see states decide to increase the amount of population mixing when they still have cases going up, and that's more than half of the states that have decided to reopen. Yeah, I mean, I'm a public health person. So I think that the goal of any strategy is to save life, and that we as a very wealthy nation can afford that strategy. But we are seeing these astonishing economic impacts that are also having a bearing on people's health and well-being, not just their income. So as Chris said, it's a hard balance.
Yeah.
David, did you want to comment?
No. I
wanted to turn back to Chris. I wanted to ask Chris a series of questions just to get into a discussion about, how we communicate data, how we communicate with the public about the public health prerogatives here relative to the data and what we're observing in terms of the public health impacts. But I wanted to just ask Chris a couple of questions about, Chris, what was the point when you realized that the model that you were working on was going to be the subject of intense national scrutiny? Can you sort of describe that moment for us, and when you realized that you were going to be in the hot seat on this?
We started off, we were asked by our own hospital system to help them plan for the surge in the hospital. So we made them a model. Word of mouth spread across other academic medical centers. We got flooded with requests. And so we decided rather than go hospital system by hospital system, we would just make models for every state in America and put them out. So we put them out on a Thursday, if my memory. And by Saturday, we realized quite what we had launched into.
But what was the point at which you realized it?
Well, I guess when the White House called on a Saturday morning, that was probably when we realized.
I think yours was the only model that that really on a systematic basis looked at resource utilization. I think that's partly what made it so seductive, because it really helped identify when we were going to max out the healthcare system, as opposed to trying to extrapolate just from case counts and things like that. Is that how you perceived it as well?
It was that, and I also think that there were, as we learned from a number of state governors' offices, there were a lot of models that were basically telling, think New York, that they were going to keep expanding to the point where everybody was infected, or 80%. And the implications of that were really so overwhelming in terms of, that was where the 40,000 ventilator number came from in for New York. And when we were trying to factor in the human behavioral response, that social distancing actually can work, and then had a sort of a different trajectory, and you might reach a peak. I think that was also part of why people were interested in that.
Did you, obviously it was a subject of intense interest. You've been on Face Nation alongside me a couple of weeks in a row, and you've been speaking to your model a lot. Any lessons learned that you would share with the group in terms of trying to communicate information and data in this kind of a setting where there is so much scrutiny and where the stakes are so high in terms of how people interpret the information and what they do with it?
Yeah, I think in academia, we love to stress uncertainty in models and talk about the range in modeling outcomes. And that's appropriate, scientifically rigorous, statistically appropriate. But of course, or at least my perception is that in the policy arena and in the public communication, that is irrelevant. What matters to the public and actually to many decision makers is what's your best estimate, your best guess, because people need to act on that. And so it puts a little bit more pressure on us in academia to do as good a job as you can and not say, my range is from 1,000 deaths. I mean, there's a model out there that the range is from 1,000 to 1,000,000 deaths by the summer. Sure, they're very likely going to be right, but it's not super helpful if you think of uncertainty as your way to communicate to the public. So that's one observation. The other one is just how, as you know well from your engagements, trying to pick one message per engagement and stick to that message, because you can't get multiple messages across per engagement.
Any other observations from the group on just how to communicate effectively in this environment when we're trying to communicate information and data that's going to be the basis of important decisions when the stakes are so high, not just the public health stakes, but the political stakes, the economic stakes? There's so much intense scrutiny on the data coming out of models like yours, Chris, or just the data sets that we're accruing from, daily testing or daily hospitalization rates. Any other observations from Mary, Heidi, David, anyone else want to weigh in on this?
Well, I'll just weigh in. I mean, I think Chris is right in terms of the best estimate, best guess, and sticking to one particular message. But on the other hand, I mean, we see here in the UK, they got it too punchy and short, and then there was a railing of complaints from public and others saying, that's not good enough. What does that mean? And people want a bit more detail. So it's finding this balance between, okay, give us the headlines and then tell us how to get there. Not that Chris, in your, I mean, for the kind of briefs you're doing for the policy level, that's one thing. But at the next level, when you say stay alert, for instance, here, what does that mean? So I think it's this balance of keeping it brief, but also what are the actions? What are the implications for people's decisions? What does this mean for my decision? Because the
think
individuals, sorry, go ahead.
No,
just
please finish. I'm sorry.
I was just going to say, it's true that at a policy level, they're weighing economics and health, but it's true at an individual level. Individuals are weighing those. You know, I really don't feel comfortable going to work, but I got to pay for my rent, or I need. So they're also weighing, you know, which risk is going to be harder on me. Go ahead there.
Mary,
I
sorry.
was just going to say that I'm not sure, I mean, and this is me also, how literate we are about how to assess models and the extent to which we understand why they vary, whether it's what's being put into them, the data differ, or it's what's being built into them, the conceptual structure differs. And so that makes it more likely that people will take them as sort of received truth when they aren't educated as about you know, about how they work. I guess it would be interesting for me to hear from Chris what he thought were the main action items. I felt very assured with your remarks that you made about, you know, these may change as we get more data. These are models that we make based on the available information at this time. They only, you know, project out over a certain period of time. I found that all reassuring.
Yeah, I've been trying to get the public, albeit I think it's a long, slow process, to think of these models like weather models, right? Lots of data flowing, weather
we
forecast.
Can't change the weather.
Yeah.
We can change the outcome of this virus.
True. There's somewhere between weather and economic forecasts, right? Because there's a behavioral element. But, you know, just the idea that forecasts should change as we get more understanding, more data. There's a lot of wild cards here. It's not something that you're going to do once and, you know, this is what's going to happen type phenomenon. There's real nervousness in our community on the public health side about changing forecasts. We get a lot of feedback that you should just make one forecast and not change. But our view is nobody knows, and we should reflect all the data that's there right now. And what goes with that is this sort of new messaging that says we're not omniscient and we're going to have to reflect the data as it comes in.
Not to challenge the way you've been describing this, Chris, but I'll just sort of share with you when I'm asked about the models, my standard talk point is that this is not like forecasting the weather where you make a forecast and wait to see what happens, but when we make models, we're actually taking actions based on those models that's going to affect the outcome. So it's a dynamic relationship to the model. Which I think has been true in the case of your model. I mean, I think your model has affected policy. In fact, I know it's affected policy in a very tangible way. Those early models did impact policymakers in a very meaningful and I think a very helpful way. So that's been my talk point. But I just want to offer it. Any other thoughts, David? Anyone? I just want to, you know, I thought I'd transition. You know, we've heard a lot about health monitoring and overall testing as a strategy to sort of guide the reopening. Does the group have thoughts that we can share with how we should be effectively deploying these things? How we should be thinking about this? How do we get testing and tracing out into the workplace? Are there potential, you know, sort of pitfalls that we should be mindful of? What are some of the best practices that you've been seeing that we can give broad guidance? We have a lot of business leaders on the call right now that are thinking about how to do this in the workplace, testing and tracing in the workplace. We have state officials that are thinking about how to do this at a state level. what kind of advice should we be giving them? And I'll just throw it out to the group.
I'm happy to jump in at least to talk about the workplace aspect of it, because relationships in the workplace obviously can be fraught, and workers can have some say in what's going on or have none, and decisions to be made by FIA. It's very tough to if workers aren't involved in that decision making. If we're going to test and we'll decide what to do with that test, is problematic. Workers right now in much of the country are very scared. They don't know if their workplace is safe. I think what at least I advise employers to do in this case is every employer should be developing an infection control plan. One component of that plan is testing, but it's not separate from physical space, sanitation, PPE, etc. It's saying we have a comprehensive plan. It's going to protect you at work. It's going to think about how you get to work, make sure you don't get exposed or you bring the exposure home to your family. And we think employers should be sitting down with their workers to figure this plan out. The big three automakers just reopened, and they have they each put out very impressive material for their workers that they worked out with the United Auto Workers, saying this is how we're going to do it safely. And everybody's on board. And that means that when workers come to work, they're going to participate, they're going to cooperate, they're going to make sure they know they can stay home if they're sick, they're going to get paid. All those things are one piece. You can't just think about testing in the workplace apart from the larger issue of how we're going to make sure everybody is safe at the workplace.
When you talk to workplaces, how do you think about giving them advice? I mean, I think about it, and so I just throw this out here to sort of challenge the discussion. I think about it in terms of how do we create a level of measures that's going to achieve a certain level of reduction in risk, that if you have a case at work, you're not going to have an outbreak of X magnitude, because there are going to be cases, right? And so what we're trying to guard against is an outbreak at a work site of more than X number of cases. How do you think about that? My Google's listening in, sorry about that. And how do you speak about it?
I would say, first of all, what you do at the workplace, at your workplace, is also going to be has to be part of the larger community activity. Is there tracing in your community? What's going to happen when you find a case? But you have to recognize that you put into various protections. Is it regular temperature monitoring, asking people actively about their symptoms? Once you're opening, you've got to make sure you're protecting people as much as possible, and that they know you're protecting them, and that they're going to tell you immediately if there's an issue, that everybody's going to play a part. And recognizing there will be cases, people will be bringing cases in, there's no question, but you want to make sure that you catch them immediately and everybody's on board together. And it's got to be collaborative. I mean, that's the thing. I mean, if people feel like it's being done to them, it's not going to work.
I think that that's a really important point, and I've been trying to figure out how to articulate it well. But this can't simply be a surveillance activity or an enforcement activity. In the end, the ability to control transmission of this virus depends on the behavior of individual people. We can't watch people all the time. So it's very important that it be viewed as a collaborative effort, as David has just said, as one that's based on social solidarity, that people look after themselves, declare their symptoms because they want to look after their personal health, their family's health, their community's health. So if somebody's afraid that they're going to be fired if they test positive, which happens now, this is not a good thing because that's a worker who doesn't want to be diagnosed. Now, that is not consistent with any logical disease control plan, but it will happen if people feel as precarious in their jobs as so many workers do in the United States. So the UAW is a union. Most workers don't have that. And so this is one of the predicaments that we're facing. And it worries me. So much worries me. I'm waiting for people to say the positive stuff. So thank you, Scott, for that.
Oh, what else do you think, just to follow up on the point, what else do you think work sites can be doing to make sure that turning over positive cases non-punitive, or trying to build that shared sense of solidarity and community around the importance of, self-identifying and self-isolating?
That's stuff that costs money, right? It means that people have to have sick leave so that they don't come to work when they're sick. They have to have health insurance so that they go to the doctor to be assessed. These are things that our colleagues in the UK don't think about, but it's something that we have to think about in the United States. And I think we'd all be safer if we could implement these changes sooner than later. I also, just on a technical point that I don't know who on the panel can answer, but I know that there is pooling done of testing in Europe. They're doing it. I believe it was in Germany. They made it a centerpiece of their strategy. I don't even know if that's going on, but it certainly makes sense. Temperature monitoring makes sense, but it will only identify people who are symptomatic. So, all of these are better than nothing. And that helps, just like face masks, are not a perfect intervention, but they're certainly better than nothing.
No,
Our worker protections like health insurance, sick leave, protections against arbitrary firing.
Chris, and then David, I think you had a comment as well, David?
No, I think I'm happy to pass on this. I think I've said plenty.
Chris?
I was just going to say that in addition to the important things that were just discussed, two central issues I think in terms of the workplace that employers can help catalyze. One is wearing masks. I think the evidence is there aren't great studies, but there is certainly evidence that suggests it may cut transmission by a reasonable amount. And even if you go to the low end of those studies and it cuts transmission by 20%, if you're just close to an R of 1, that's plenty enough if it's widely used to keep you well below. So it may turn out to be hugely important. And then the second one is, if you look in a country like New Zealand that's done such a good job of essentially tracing everybody and screening, what we've learned from New Zealand is that half of all transmission is from large transmission events, at least in that country. And that really, I think, puts the onus on employers and local governments keeping the limits on group gatherings down to a pretty small number, like 10 or less, just to avoid the risk of those 100 people transmission events that we've seen quite routinely.
Well, and this is going to mean then that as we reopen the country, it's the larger workplaces that really could be the threat. And these assembly lines, especially where people are relatively close to each other. And so we probably have to think from a social level, is there some way to subsidize the costs of workers staying out if they're symptomatic or, if they've been tested positive? Right now we're saying essential workers only should be out for self-quarantine for a week rather than 2 weeks, which is problematic in itself. On one level, it isn't fair to have all those costs fall on the employer, or if they push it onto the workers. And so this is sort of like an eminent domain cost. If the government is insisting on something, and we need this to stop the epidemic for everybody's sake, we should be thinking about additional subsidies for workers to stay home in those situations where they really have to.
Just to change topics a little bit, I'm going to turn to the audience questions soon. We're getting a lot of good questions, and I think I have like 260 questions right now. But as we reopen, what should we be looking at? How do we know that we're entering into a dangerous zone? And can health monitoring provide this information, the data that we have right now? How should we be looking at the models? Should we be looking at testing data? How should people think about this?
Your best bet, in my view, is still going to be watching really closely hospitalizations. It's the most comparable indicator over time. Short of that, watch the cases, but you've got to correct for the scale up of testing. And there's a way to do that. Because if you don't, we're getting already in our state here, essentially a false signal. You know, the confirmed cases are going up, but hospitalizations and deaths are going down. I put more faith that the epidemic is actually petering out because of those. But those are your early warnings right now. They're not super early, but that's probably what you've got to focus on, to sound the alarm.
Can I just push on that a little bit? How, in terms of modeling the impact of a policy change and the consequence in terms of an expanding epidemic when you're looking at hospitalizations, what is the lag? How much of a lagging indicator is hospitalizations?
So, you know, again, people will argue on the edges, but roughly speaking, the time from infection to death to those who die is about 18 days. It's up to 21, down to as low as 16, but it's about 18 days on average. And you can parse that into about 8 of those days are from being admitted to death. So you can reverse that out and say it's about 10 days from infection to hospitalization. So it's a 10-day lag on what's happening in the community. And it's about the same for confirmed cases. It's also about a 10-day lag. So it's a lagging indicator of what's happening in the community. And we haven't got a great strategy yet that's, you know, ready for prime time to look for something that's going to be less lagged.
And this is why a lot of the reopen plans in states have sort of 2-week intervals built in, because they're looking at hospitalizations, but they want to wait a full replication cycle to see the impact on hospitalizations. Is that what you'd be recommending if you were designing policy, that kind of an interval between stages?
Yeah, I mean, I think the way to you can use the model to be helpful on the timing in the following way, in the sense that where are you getting headroom to like relax social distancing? You know, what's changing in a setting where, let's say, transmission is just below 1 or so in terms of that famous R value. And there's only 2 things that are going to create headroom in the meantime. One is what small temperature effect there is and seasonality. That may turn out to be bigger than we think, but that's one factor. And the second one, of course, is scaling up testing and contact tracing and isolation. Again, statistically very well correlated with reductions in transmission. So you've got to expect that you've created some headroom there, and then you can start to think about that and then look for confirmation that hospitalizations are on their way down. Cases after correcting for testing are on their way down.
Any other thoughts from the group on this in terms of what we should be looking at as we reopen to try to gauge directionally where we're going? Chris, I think Chris summed it up pretty well, and he's in the business of doing this, so.
Yeah. But you also, I mean, I think from the data point, absolutely. But I think also the readiness for people actually to start, for things to start opening. Does everybody know what they're supposed to be doing in whatever the work setting or if schools start opening or whatever? Do they know what they need to do? Have the staff been briefed? Do you have enough masks? If you promote masks, are they available? What do we mean by distancing? I mean, here in London, there are lines on the streets, and in front of the fish shop, they have painted fish every 2 meters to know where to stand on the buses and the tubes. We're surrounded by the end of the day, if you don't know what 2 meters is, you know, you haven't got very far out of your house because it's everywhere. So there's the data that defines what technically is a good time, but then we need to have the readiness to have that kind of all hazard protection. So people, once they do start coming, because the data and this from what Chris was describing, where we are on the curve, and that's really super critical. But then the other side of it is, are we ready from a preparedness point of view?
Scott, could I just say something
Sure,
about
please.
the trigger? Because I don't have a number, but it seems to me that it's a good idea to have some kind of predetermined strategy for how you're going to identify a surge. One that is explained to people so that with some luck, perhaps, that when the hospitalizations start going up, the intensive care unit beds are full, the number of, faced with robust testing, the number of newly diagnosed tests go up, that people aren't surprised that this is what they thought would happen, and then the actions can be taken, and a difficult decision will maybe be a little less difficult.
It seems like it's going to be awfully complex to go backwards if you do have a surge to re-implement mitigation steps, just as a political matter, as a policy matter, as an economic matter, a social matter. But what we might do is slow down a reopening based on the data, and stage it out more. And that's not to say some states might not have to go backwards. I just think it's going to be very hard for political leaders to make the decision to do that. I think it's going to be a lot of pressure on them. And that's why we need to get this right, I think, as we go forward.
And the other thing that Professor Lawrence mentioned, I can't help but take advantage of such a great panel, is something was discussed in an American magazine recently, that people, regardless of what we tell them, will try to rank their risks. They'll try and make a decision on what's the riskiest thing to do, what's a little less risky. And that's something that that we in public health haven't engaged in yet when it comes to this virus. But it might be a good thing to think about and to gather data on. Are outdoor activities safer than indoor ones? It stands to reason they would be. Does it make sense to start expanding the number of people who you trust are not infected beyond your household? How would you do that? Those kinds of things people are going to want guidance on.
Sorry, but Facebook has been collecting a survey of 1 million people in the US a week with quite a long list of questions, including how many people do you come in contact with? And so if you really want a leading indicator, we need to validate that actually predicts transmission, but it may turn out that it does. And so you might actually get an indicator that is 10 days or even 12 days sooner than seeing the numbers show up in your data feed. So, I think that's something to watch carefully to see if that does predict the next 2-week period in some way.
Just a final question from me, and then I want to turn it over to the questions that are coming in. But personal decision-making of individuals across the country is going to make a big difference as we reopen, whether or not people become complacent. Do they still practice good behaviors to try to reduce transmission, good hygiene, good hand hygiene? Do they wear masks? What type of strategies have we seen that have proven successful in motivating people to follow those preventive health measures in the past, where you can sort of sustain it in perpetuity and you don't get complacency among the population? Any lessons that we can give to employers, state officials, local officials about how they should be thinking about engaging the public and just making sure that they stay vigilant?
From the OSHA point of view, I mean, the focus of the OSHA law and all of my work was always on employers, and there's a range of interest in safety among employers. Some are incredibly committed and want to do the right thing, and others are really not. And what I've found is that recommendations, guidelines are really useful for some, but many employers will say, well, I can't really do that. And unfortunately, the way to motivate many employers to do the right thing is you need a law, you need a standard. And unfortunately, from the federal government, they've made it very clear we're not going to see OSHA standards saying you've got to protect workers from COVID-19. Some states are weighing in. Governor Baker of Massachusetts, actually 2 days ago, announced that he will issue an executive order with emergency standards for Massachusetts workers. But until we see essentially a law or regulations, we know from the meat industry, the CDC has been putting out very good recommendations for months now. We have 10,000 workers in that industry and 50, who are infected and 50 who have died. So unfortunately, motivating people in some cases will need essentially a requirement rather than just a recommendation.
Anyone else want to weigh in?
Well, it's hard. I would just pick up on what David had talked about earlier in the context of the workplace and the engagement of the workers in the decision making. I would take that principle across the community in whatever the place or the community, or if it's whatever the setting, that it involves people and they understand why they're doing these things, why it's important, that there's some structural nudges that help along, which, I mean, whether it's a legal one or visual ones or other ones. But I think that principle of involving people, it is absolutely across the board important, because one of the biggest resistances, if people feel even more left out than they already feel these days on decisions being made, it's a quick way to lose them. And yeah.
So I want to turn to some of the questions we're getting from the group, and so I'll start with this one. What is the most valuable single metric for the lay public to track, such as the R naught number, to understand how the pandemic's evolving in different parts of the country? So, what do we say?
I'd have to put my money on what's happening to deaths. Although it's got warts on it, it's way more robust than anything else. Are they going up or down?
And it's not hard to diagnose.
But a lagging indicator. I mean, it's going to take time to see an impact.
Very lagging. Yeah.
Next question. Do you have specific guidance for colleges and universities, in particular housing considerations, and how to quarantine, self-isolate positive cases and a potential roommates or apartment mates? So what guidance do we have for universities heading into the fall that want to contemplate reopening, assuming that we have have conditions that would even enable it?
That's a very hot topic in our sector. I think large classes shouldn't be on the cards. Some pretty strict limit to class size if you're going to have in-person instruction. And then the dorm issue, there's lots of ideas floating around there about where you put people for isolation purposes that test positive. Can you afford to have regular testing? I think there'll be a lot of discussion in the next month to try to weigh in on that. Going to be a challenge.
Any other thoughts from the group? I'm looking at you, David. Any thoughts on that?
Oh, it's tough. I mean, that's exactly the question. I mean, I can see universities going to a hybrid model where some classes or parts of classes are online and people attend different things, but the tough issue is housing and meals as well, but housing in particular.
Okay. So here's a good one that we kind of touched on, but I'll put it back. These are all really good practical questions. The public's coming out of their homes and soon, ready or not. give our best advice for that scenario, not shaming, but practical guidelines and advice for people on how to lower their risk. What should we be telling people about how to lower their personal risk?
Wear a mask, stay 6 feet away.
Wash your hands.
Exactly. Wash your hands.
Wash your hands.
Do we have a sense yet how much of the transmission here was from contaminated surfaces versus respiratory droplets? Do we think that this is following sort of a traditional pattern of other respiratory diseases in terms of how it's being transmitted, or could more of this be through contaminated surfaces versus respiratory droplets? Is there any literature or sense of that? No.
I mean, I think that just talking to clinicians, I think most people think that the principal mode of spread is respiratory spread through either droplets or aerosols, as opposed to fomites. But I don't know of any detailed studies that establish that.
amazing how much we don't know about this
It
pathogen.
really is, but we've only known about this pathogen for a couple of months. So.
Here's another one. Within a workplace, what are some of the best practices? What should happen if a case is discovered? What should the employer do from both a public health and a communication standpoints? What kind of practical advice could we be giving workplaces? And if David, if you don't weigh in here, I'm going to call on you.
No, that's exactly right. I mean, first of all, in advance, you've got to have that culture so people are working together. But you've got to say, you've got to have a place to isolate people and send them home. Obviously, if they're there when it's discovered. But you want to be able to make sure that people are safe, that they're able to space, distance out. There's sanitation, there's disinfection, obviously, in the area. If for no other reason, that's sort of reassuring to everybody that the employer cares and the area's been cleaned. And you bring people together and say, look, we had a case here. We want to investigate to make sure that if there's a risk of exposure at the plant, because the person was exposed to someone else, for example, that we've investigated that. One of the real problems is, my old agency isn't telling employers to do that. And I think it's really important to go out and say, if someone is infected, let's not just assume that they got it because they got it from their spouse or partner, or they got it in the street. If it's happening, it could be happening in the workplace. So it's really important to follow up and bring people together and say, look, we have someone here who got sick, we're going to make sure it doesn't happen again. A lot of it's common sense and following CDC recommendations, but the way it's described, how you get the workers involved, if there's a union to bring them involved, is really key in some ways. That's as important as the specific, how do we respond, technologically to the problem.
Anybody else want to weigh in on that?
Just to say that as we reopen, it's a real opportunity to gain more information. And I just hope that it will be possible, at least in a handful of settings, to do universal testing, to see what happens in terms of in terms of workplaces, in terms of rising number of infections. So we have a natural experiment unfolding.
So here's one about, the question is, please address the utility of using mobile data as one of the triggers for a surge, and how to communicate that people are being tracked and that their data is being used. But how do we think about these tools, and how much utility do they have relative to the political sort of intrigue that they're likely to generate if we try to use mobile apps and other kinds of tools for track and trace? And just sort of follow up on that, if we're not going to be able to use them at a population level or by local health authorities, could we use them in the workplace, where employers it's going to be incumbent upon employers to have some system in place to do track and trace within the workplace in case they have an infection in the workplace? Can they be using these tools just within the confines of the workplace? Any thoughts on that? On using them generally, or just using them in a more isolated fashion?
I don't think in the workplace, I think you actually need them less. You know where people have been. You know who they've been with, except in, perhaps giant workplaces. That's not the question. The bigger question is sort of outside the workplace, in the community, other institutions open up. I think workers would be very concerned if there were track and trace only in their workplace, using an app or something like that. This follows you where you went in the workplace. I think people have to be very, use that very gingerly, I would think.
Any other thoughts on using these at a population level? We've seen a lot of concern raised among some about the application of these tools. We've seen countries use them successfully, though. Not just the sort of tools that give you proximity, but tools even just for giving people a risk score of their overall risk. The pipeline that Google and Apple built, and how we can make practical application of that. Any thoughts about how we make better use of these tools, if at all?
Well, there's an interesting initiative out there. I don't think it's ready for prime time yet, but basically, if you are going to go out and go somewhere, there's a consortium on the tech side to tell you where other people are, so you can avoid large crowds or lines. And I think that's the sort of tool that will empower personal choice. And, you know, in addition to wearing a mask and avoiding other people, you can avoid crowds. And so there may be real value in that to helping guide individual choices ahead.
And on an aggregate level, I've seen the use of cell phone data just to look at how much people are moving around. And it does support the fact that people have stopped moving around as much. I just worry about it, and I guess that's why we're all being quiet, that I just worry about the punitive bent that seems to often enter into considerations of how to reduce transmission, that a community that moves around a lot may be a community with many essential workers who have to go to work, as opposed to a defiant community that's not following the social distancing rules. So those are the concerns that we have.
You know, we use very extensively cell phone mobility data in our modeling by state from 4 different providers, not vendors. So it's very predictive in the past of transmission. Yeah. And it would be, you know, it's a central part of how we're sort of viewing how to see the next month or 2 unfold. The degree of detail that is publicly available is down to the census tract. So it's really extraordinary detail about who and how America moves in a way that, you know, like it's understandable why the government's reluctant to make much use of that data because of the perception that the public might have about that.
And also maybe the answer should be that work should be safer, that public transport that people take to work should be safer, and not, you know, that the people are moving around too much. I mean, estimates are that 40% of the workforce has been classed as essential. That's a lot of people who are still going to work. So rather than saying, you know, are these people moving and they shouldn't be, maybe it would be better to think about the kinds of things that have people moving and how to make those activities safer.
So, Chris, can I ask you what you're seeing in the data on movement? Can you share with us some insights?
Yeah, I mean, it's on our website now. If you go to the state page, you can see, because we take the 4 sources, we put it together, we give you the line of mobility since, you know, the beginning of March. And, you know, it's super interesting by state. What we saw is as the national discussion turned to relaxation, mobility started to go up even in advance of relaxing the mandates. So, and we saw this on the way in when there was started to be a discussion in the state in March about putting on mandates, mobility went down. Some employers encouraged work from home. So you see anticipatory changes. We saw that on the upswing in late April. We're seeing big swings up in some, but not all states. So that's definitely happening. People are out more. The pushback we get is, are they out wearing a mask and being very cautious? And therefore the mobility data may exaggerate transmission. We'll start to get an answer probably next week, you know, because the mobility rise start at the end of April. A couple of weeks in, we'll know how well it's predicting you know, transmission.
The mobility increases that you've seen, how do they track relative to a baseline? What's the percentage of current mobility relative to what a normal set would look like?
Okay, so if you go and look in Italy and Spain, take Madrid, let's say, right? They put on social distancing mandates, mobility dropped 90%. Same thing happened in New Zealand. They put on lockdown, 85, 90% reduction. The biggest drops we've seen in the US are about 55%, the smallest about 40. This is back in March, you know, when the mandates came in. Americans are just more mobile, it seems, than others, but that did translate, even in New York, it's about 45% or 50. That translated into a peak and a decline. And now we're seeing a bounce back of going from, you know, a 50% reduction in those units back up to like 30 in some states. The worst might be 25. So we're already halfway back to the declines that we saw in March in some states. which is why our models are shooting up in terms of our forecasts. Actually.
That's pretty profound. I mean, that's a pretty profound change in a short period of time in behavior.
Very, very. People are sick of quarantine. Our worry is that they will sort of anticipate the next move, and they're getting out there and potentially having contact.
Are there temporal trends in activity? I mean, at times of day when people are more mobile than
Oh
others?
my goodness, the stuff is fascinating stuff if you dig into the detail. The weekend effect in Italy, during the lockdown, they had these very big reductions, except on Sunday, where people were still somehow going to church. So there's books to be written by people like Heidi, the anthropologist, and others on what all this means, and it is a new insight into human behavior that I don't think we've had in the past.
At the center I work
Yes.
at, where there's been a lot of focus on migration, and the cell phone data have been in use for a while.
Yeah.
It is interesting.
There's a question here whether or not how far we think we'll get to herd immunity before we get a vaccine. I mean, if we continue on this sort of slow burn, doubling time every 45 days or a little bit more than that, if we just continue where we are right now, by September we'll probably have 10 to 15% of the population exposed. If we don't get cases down more from where we are, what do we think about that? How much of the population? I mean, Chris, have you thought about this, or anyone else in their modeling?
We spit out, and we haven't made it public, but we do spit out, what would be, I mean, we have infections in there, but easy enough to get the cumulative infections and likely antibody testing. Currently, if we hold where we are on the mandates, we think nobody's going to tip over to an R greater than 1 for a sustained period. They have a short period, temperature testing kicks in, and we go back down below. So probably won't get much, as you said, numbers well above 90% of the US still susceptible. But as we go into the fall and another wave comes back, if mobility ticks up because of either fatigue or we also get the combined reversal of seasonality or temperature, we will start to see more. And it's down to this task that we find very hard, which you talked about, Scott, which is, will governments at the state level be willing to reimpose mandates once taken off if things get bad enough, right? If you tip over into, a faster doubling time, is there a level at which they'll say, no, we need to go back to some mandate? And that's almost the imponderable to stick into the modeling to answer the question you're asking.
Any other thoughts from the?
Yeah, but we still don't know how long immunity lasts. I mean, we had all these discussions here on this idea of an immunity passport, but the reality is we don't know after someone who's infected and recovers if they'll have protection for a month, 6 months, a year. So it's a dynamic state. It's yet another question we're trying to understand. So the concept of herd immunity has a number of still uncertain variables, aside from whether it's 60, 70, or 80 or 90% that you need. I've heard everything from 70 to 80, but still the length of protection is still uncertain.
It's an interesting question here about the term reopening and whether we're communicating appropriately about the sort of post. They use the term post-lockdown phase. I probably wouldn't refer to it as a lockdown, but so maybe the lexicon needs to be cleaned up on both sides. But it's a good question about whether or not we should be talking about this differently in terms of the kind of behavior that we're trying to inspire, because we're restarting activity, but we want to restart activity very differently than what it was before. Any thoughts about that, about some better ways to be speaking to the public about what this phase looks like and what it means to be in a reopening, if you will, or what the better way to talk about that? can move on to the next one while people ponder that, which is because I think it's a good question. So let's think about it so we can come back to it. But the other one is what would be recommended for testing intervals if a business is trying to test employees to do sort of background surveillance or do routine sentinel surveillance within a large employee setting. Has there been any work done on that we can identify a point to, or any thinking about how to do that?
This is a question about the frequency of testing.
Yeah, or setting up some surveillance testing in a work site where you have at-risk employees. People can't naturally social distance at work. Think of like a shop floor, grocery stores, things like that.
I've seen things, but I can't tell you what the backup is. Like a suggestion that people be tested every 2 weeks, but I can't tell you what the backup is for that.
And until a lot of the whole testing system shakes out in terms of accuracy, the sensitivity of some of these cases, we're just learning about the sensitivity and specificity of some of these cases. So I think until we have some real better numbers on accuracy of these tests, it's going to be very hard to say here's the right protocol.
I have to say, yeah, then when I think about what reopening will mean in terms of how stratified the amount of social stratification of risk that will be amplified by reopening. If someone like me works at a university, I'm likely to continue working remotely a lot of the time, whereas many other people who are more likely to be low-wage workers and in settings where their risks may actually be higher than mine would be at going to my office, will be going back to work. And I'm just concerned about that.
So here's a question about the health implications of the economic shutdown. What do we think we're going to see on the back end of this, particularly on this says particularly on low wage workers and minorities? How do we prevent further economic and health disparities resulting from the shutdown separate from the disease itself? So what can we say to that?
I think the thing that we're, oh, sorry, Heidi, go ahead.
No, I was just, go ahead. I was just saying it's a big challenge.
I really think that we need to do the full health effect modeling. It hasn't been done yet, which is both arms, the direct effects of COVID and the effects on health that are mediated through lost unemployment, increased poverty, increased inequalities, and see how that, just from a pure public health point of view, what does that look like? Because we've been focused on naturally, appropriately, in the setting of an acute pandemic on the direct effects. Nobody's really wired up the whole pathway through the economic effects back to health. And I think that should be a priority for us all.
But those are also, we must say, modifiable. The economic impact can be modified by social decisions on providing people with more resources to weather the storm. They're not fixed.
But we're not doing that adequately.
We're not, but I mean, we're not doing that adequately. But that's a political decision.
Right.
It's not some kind of grand machine of our economy, which, Chris, is sort of what I thought you might be thinking of.
No, I just think we need to look at the policy choices in both spaces and how they influence both sets of pathways.
No, people who were worried that shutting down would cause more actual health consequences than the virus it would have there was a basis to that concern. There's no doubt.
I mean, just look at basic childhood immunization rates have dropped, and that's one of many health interventions that people would have done normally are not.
Yes. We should figure that out.
Well, that should be part of the reopening. If we talk about,
Yeah.
if we're talking about reopening the economy, how do we make sure that, the people who have been affected by this in negative ways, we can immediately try to address those?
Chris, there's a lot of questions here. I've screened them because I wanted to spare you, but there's a lot of questions about your model, and a lot of them I actually desperately want to ask myself. So I had to exhibit immense self-control. But one of them, which I think is interesting, is what kind of data do you feel you're missing? What would you want to incorporate into your model that you're having difficulty getting, or you feel the quality of the data is not sufficient?
The top number one would be to get for every state and then preferably every county, because we're going to move to the county level for our model quite soon, is daily admissions to hospital. We only get that from a subset of states, and in some states, including some big ones, we don't get admissions. We get the census count, like how many people are in hospital, and that's a very lagging indicator, the census count, as opposed to admissions. So that would be a really useful, not just in terms of tracking, but in terms of calibrating the biases that are in the cases, because we know the case data has these sort of complicated trends in them. The other one, as we move into this phase that I mentioned at the beginning, where testing is going to be such an important part of the strategy moving forward, is much more detail on testing. Who's getting tested? Are they symptomatic? Are they at-risk vulnerable groups? Testing by age and sex, socioeconomic status, race, ethnicity, all that extra information that will help us identify where transmission may still be occurring. And I think that'll feed into this general push that everybody who's looking at the epidemic is got, which is to be more local. We're seeing the meatpacking plant epidemics, the prison outbreaks. These are now starting to be huge signals, but they can really throw you off in a state if you're not aware that that's a particular at-risk population. So more detail on that's going to help an awful lot.
Are you, do you find yourself having to adapt the model now that we're reopening, or is it just a matter of different data inputs and the model itself stays relatively intact, or does the model have to change with different assumptions?
We're on our 4th generation model to try to adapt to a changing pandemic. I am sure we'll have a 5th or a 6th or a 7th generation. The way we handle that is we've got a development team, a bunch of smart statisticians, mathematicians, others, and then we have a separate production team that runs with whatever the current best model we think we have is, intakes the data, runs the models, does quality checks on those, and does what we think is really important is, did the results make sense? Because there's also an element here, because of the vagaries of the data that come, where sometimes, for no fault to a state or a public health department, one day they report 6 deaths and the next day they report 160 deaths. And of course, any modeling effort really struggles with that, to say the least. And so the noise in the data is also a challenge. And that's why we sort of separate the development team from the production team, because the production team's pretty busy just trying to make sense of what's coming in. Interesting.
So what's the next update going to show? I promise I won't tell anyone. I'm kidding.
The thing that we're pushing hard on is for the U.S. We're moving to other countries in the world. We released Latin America yesterday. Brazil's going to have a really big epidemic, not quite as big as the U.S., but pretty similar in magnitude. We're expanding to many other parts of the world, and low and middle income world. But for the U.S., it's the push to county level, and it's the push to be able to map out what would be low risk strategies for relaxing different mandates over time.
Well, I want to thank you, Chris, for those insights. So wonderful. I want to thank the whole panel for a very provocative discussion. It's clear we have a lot of challenges ahead. There's not a broad consensus in this country on what we need to do, and I think it's really important that we get together like this and explore ways to explain these things better to the public, explain how people can reduce their individual risk, how we can deploy these kinds of tools, increase the vigilance, increase the sense of shared sacrifice around keeping people safe. People, I think, going forward are going to need to do things differently, and they're going to need to take on some level of community and shared sacrifice to keep each other safe. And I think it's going to be incumbent upon us as public health officials and as people who have access to data information to make that available to people in a way that can help them understand their individual risk and help them understand how they can reduce their individual risk through simple interventions that they can do in their daily lives, that workplaces can do, how we identify the at-risk communities and get resources and targeted services into those settings. And so this is a great discussion along those lines. I want to thank you all. I want to wish everyone a good night. Thanks so much.
Thanks.
Thank
Okay.
And thank you, Heidi, for all the way from the UK.
Yes.
Very good. Well, thank you all.
Great. Bye.
Thanks. Bye.
Good night.